Thank you. That was a very wide-ranging and complete look at care, at everything you all probably know better about than we do up here in spite of our positions as speakers. Let's have a few minutes for questions before we hear from Gary. So there are 2 microphones. I don't know if there are questions that you have. Certainly, if there are questions, we're all going to be available through the next 2 days. But I do think we have a few minutes for questions. If anyone has any, I think we also might have a roaming microphone. The panel can take these. Hi, there's someone I know.
Hi. Check. Hey.
Yeah, you need an extra 6 inches on the microphone.
I know, right? I'll
Go
crouch.
ahead, Kaylin.
So one thing we didn't hear about is detection and imaging. So I wanted to hear from the group is if there's anything coming down the pike to detect cholangio sooner, both at the onset and also in the instance of recurrence.
Yeah. Can you hear me, Zan? Okay. Yeah, that's actually one of the hardest things. So right now, really the basics are going to be CT, MRI, ultrasound, but ultrasound is very operator dependent. So if you have a good sonographer, it's great. If you don't, it's basically worthless. PET scan we use on occasion, but mainly to look for outside disease, not what's actually there. Endoscopically, there's all sorts of new techniques that were been coming along, things like spyglass or Cellvizio, which are basically microscopes at the end of the scope. So you can imagine you have an endoscopy that goes through the stomach, then you cannulate the bile duct with a little microscopic microscope, essentially. And so you're looking at areas that may look inflamed, and the idea there is to target the biopsy. So you're targeting what you think is the most likely source of the cancer. Because right now, the brushings that are the standard of therapy, it's basically a flip of a coin. So there's nothing beyond that as far as early diagnosis. There's not much. I have to say, in the spirit of full disclosure, that the Cholangiocarcinoma Foundation actually funded one of my initial projects to look at biomarkers, and so biomarkers are probably going to be the next thing. The CA19-9 is just not that good. The last point I make to that is that surgeons, I have to basically assume that when I see a biliary stricture, that it's cancer until proven otherwise. I'd say that it's about 90% cancer, 10% it'll be that autoimmune cholangiopaty. And right now, I just don't have the ability to miss a cancer.
Any other comments from the panel on that?
I can say also one of the, I don't know if this is on. Is this on? Yeah. One of the other technologies that's big in cancer right now is looking at blood-based biomarkers, as Dr. Flavio was saying. So I also study liver cancer, and one of the technologies that we're looking at is circulating tumor cells. These are cells that are shed by the tumor into the blood. And so we're looking in patients who are high risk, who are likely to develop liver cancer. So for example, people who have cirrhosis from hepatitis B or C or alcoholism, if they are shedding circulating tumor cells early on so we can catch their disease early. It's not a way to prevent the cancer, but as we were talking about 20 to 25% of patients with cholangiocarcinoma are diagnosed early enough for surgery, and about 75% a little bit too late. And so if there are technologies that we can figure out when it's diagnosing it early, obviously it's beneficial for everybody because that has people have a chance at cure. So there are certain patients who are at high risk for developing cholangiocarcinoma, like primary sclerosing cholangitis, patients who have that disease. So I'm not aware right now of big efforts to look at circulating tumor cells for patients who are at high risk for cholangiocarcinoma, but I'm sure people around the country are doing it, and I'm sure those studies are coming.
Thank you. We have another question.
I'm very interested. Is this working? Can you hear me?
I can repeat it if it's not.
Okay. Oh, there we go. So I'm very interested in the immune therapy. I agree this is, has potential great future. You mentioned that colitis was one of the side effects and the worry of taking out the restraints of the immune system. A lot of patients have inflammatory bowel disease and primary sclerosing cholangitis. Is that a contraindication? Are those patients still eligible? Do they seem to be at higher risk for an inflammation of their other inflammatory disease?
That's a very good question. So there's the CTLA-4 antibodies and the PD-1, PD-L1 antibodies. The PD-L1, PD-1 class, they tend to cause less colitis than the CTLA-4 class. In terms of the trials, a lot of trials unfortunately do exclude patients who have any kind of autoimmune disorder, such as ulcerative colitis or primary sclerosing cholangitis. But obviously for cholangiocarcinoma, right now a lot of the studies are basket trials, which means patients with any solid tumor, not specifically cholangiocarcinoma, although there are some specifically for cholangio. I don't know if anybody else in the room has had more experience with this, but in talking to our melanoma doctors, because I do sometimes give immune therapy, we do consider giving immunotherapy to patients who have a history of ulcerative colitis or primary sclerosing cholangitis. We just watch them very carefully because obviously you can rev up the immune system. I haven't actually given it yet, but I don't know if anybody else in the room has given it, but we do consider it.
Well, I'll give you an example of a patient of mine who had actually a melanoma spread to the liver that I resected, and then we decided to give him off-label combination immunotherapy. And he had a dramatic response, has not recurred, but he developed severe colitis to the point that we actually gave him IBD therapy in the end. We actually gave him anti-TNF, Remicade, to try to actually mitigate the symptoms. And so in some ways you can overstimulate the immune system, get the effect you want, and then you got to rev it back down. But this is where I think these trials are very important to try to actually regulate which ones can we do without harming the patient.
Juan, did you have a comment?
Yeah, just to add, one of the things that it has highlighted is that we need to work differently. These are not the same side effects that we're seeing with chemotherapy. So one of the other effects that we need to look at is the endocrine side effects, and it can affect the pituitary gland, it can affect the thyroid gland. So we need to be working with our endocrinology colleagues as well.
I want to make sure we have a few, I think time for two more quick questions, and I see one, please.
Yeah, I have kind of a rare cholangiocarcinoma because, according to my oncologist, it's not behaving the way it's supposed to, so I don't know what that means. But it has metastasized. So my question for you is there any sort of percentage of the number of these cancers that migrate to other organs versus go the bone route?
Juan, you want to tackle? I think the question is, how often does this cancer spread or spread early?
No, the difference between it going to the bones
To the bone
versus organs.
Okay.
Okay.
Yes.
So I guess for an individual, it's very difficult to say. But if you look at all of our patients, the usual places that we find that it metastasizes to is the lymph glands, elsewhere in the liver, and it may be the lungs. But we do have a relatively small percentage of patients, and I guess it's less than 10%, where we do have involvement of the bone. And sometimes we don't have involvement of the bone, but you end up with a problem of a high calcium. So you produce a hormone that effectively overstimulates the production of calcium, and that can be difficult to manage as well. So I think it's on the end of a spectrum. But in fact, for high volume centers, we do see it relatively commonly, I think.
I have a hard time finding trials and things because of that.
I think in terms of the management, and there are some established treatments for bone metastases, and usually that applies wherever the primary is, whether it's breast cancer, prostate cancer. So we'll be thinking about things like bisphosphonates, for example, and that can be applied, wherever the primary tumor is. I think it's unlikely that you would find a trial specifically for bone metastases from cholangiocarcinoma. The treatment approach would very much be systemic treatment, as we would for metastases elsewhere. Right. The only thing, just to quickly add, is that occasionally you need to focus on one or more of individual bone metastases with radiotherapy for pain control and prevention of fractures and things like that.
Right. Okay, thank you.
Thank you. I think we have 1 minute, so do I have time for another question? Do you want to go ahead?
I know it's a big question, but aside from the normal risk factors, could you discuss the role of genetics in a person's diet as related to cholangiocarcinoma patients?
You want?
That's a big one.
That is a big one.
I can say
we'll do our best.
There's one genetic syndrome that is sometimes associated with cholangiocarcinoma, which is called Lynch syndrome. It's more commonly associated with cancers such as colon cancer and ovarian cancer. but I've seen about 2 cases now of patients who have Lynch syndrome, and it's what we call a germline mutation. It's a mutation that you can inherit from your mom or your dad, and that has probably a 3% risk of developing cholangiocarcinoma in a lifetime. But for the vast majority of my patients, we have not found a genetic component as to what's causing it. But more and more we're seeing young patients, people in their 30s, people in their 40s, sometimes even patients in their 20s. And I do believe there is possibly some interaction between environment and genetics. And I think those studies really need to be done so we can understand genetics.
Thank you. I think diet is a big question, and perhaps through the day tomorrow we can touch on that a little. Go ahead.
My colleague will give talk right now, and it's a chem therapy. It's a additional therapy, and one of the points it will be nutrition. In a general, as a palliative care team, we definitely concentrate on the pleasure feeding. If patients able to tolerate some food, this is the best one because your body is dictated. Maybe it sounds very stupid, but this is a reality. And again, if it's connected to symptoms, for example, you have nausea, we will look on the products that will be less giving you nausea. Or sometimes we're giving some medication to prevent it. We're walking around. It is a lot of studies done by nutritionists about concentrating only on vegetarian products. Some studies concentrating on high protein in food because we see a lot of sarcopenia going on. Sometimes patients still look like obese, but it's not in reality. You need a really good protein source to fight all infections that are going on, to be very strong from protein side, right protein to go through chemotherapy, operation. And we employing our nutritionists to tune individually, but it's no real established some nutrition diet for cholangiocarcinoma.
It sounds like a component. So let me thank our panel. So thank you all for coming and speaking. And I'll let them leave the stage.